pound sign, or the hash key. For operator assistance at any time during your call, press *0.
Welcome to the Corporate Medicine Section web conference. At this time, all participants are in a listen-only mode. Please do not put your phone on hold at any time during the presentation. Later, we will conduct a question-and-answer session and will open lines for questions. If you need to step away during the presentation, please keep your phone on mute. Please note that this web conference is being recorded. If you need operator assistance at any time during the presentation, press *0. I will now turn the call over to Dr. Bruce Sherman, Chair of the Corporate Medicine Section. Dr. Sherman, you may begin.
Thanks, Dana, and thanks to everyone on the call. I'd like to welcome our section members, our current section members, and our new section members who have joined as a result of the communications for this webinar. On behalf of the Corporate Medicine Section leadership, I'm pleased that you've joined the webinar, which we certainly anticipate is the first in a series relevant to section members. With us today is Pat O'Connor, who will be giving us a presentation entitled An Inside Look at Implementation of the Health Reform Act from the Corporate Medicine Perspective. By way of background, Pat is ACOEM's Director of Government Affairs. He's with the Washington, D.C.-based government affairs firm of Kent and O'Connor. On behalf of ACOEM, Pat was directly involved with the process that led to the enactment of the Patient Protection and Affordable Care Act, and he's now working with ACOEM on implementation of the Health Reform Act, as well as other federal issues that impact occupational medicine. Following his presentation, Pat will take questions from the callers, and Dana Kelly from ACOEM will be moderating those questions. And Pat, I would like to turn the control over to you. Thanks.
Well, thank you much, Dr. Sherman, and good afternoon to everybody. I apologize, we've got some slight technical difficulties on my end. So what I will do, Dana, is when I say slide, if you could just change to the next slide.
Will do.
With that, let's change the slide to the webinar overview. Next 45 minutes to an hour, I do want to spend some time providing you a look at the Patient Protection and Affordable Care Act as passed and signed into law by Congress earlier this year. I'm going to look first at the implementation timeline, what's already happened in 2010, and what we can expect in 2011 and beyond. Also want to spend some time talking about the consequences for employers as a result of the Act, including an update regarding the future of employer-provided health benefit coverage, which in my mind is up in the air right now. Also want to look at health and performance and the role of wellness and prevention programs as they apply to corporate medicine and to the workplace. And also at the end, I want to talk generally about the impact on corporate medicine and opportunities for OEM physician involvement in the implementation of the Health Reform Act. Also want to turn right now to an item that's not in the slide set, but this is the impact of the elections on health reform. There has been a lot of discussion in the news media, both radio, TV, and in the newspapers, and certainly on the Internet as to the impact of the November elections on the future of health care reform. My first admonition to you would be to everything you view or read, do so with a grain of salt, as my mother used to say. No one today knows for sure what the new Republican leadership strategy will be with respect to health care reform next year, and no one can say for sure what the administration's approach will be to defending health care reform. What we know, though, for sure is come January 3rd, when Congress reconvenes, the Republicans will hold a sizable majority in the House of Representatives. For that reason, it's entirely likely that the first bill to be introduced in the House of Representatives come January will be H.R. 1, H.R. being the abbreviation for House Representatives, H.R. 1, which will be for a complete repeal of the Patient Protection and Affordable Care Act. That bill will in all likelihood pass the House with little difficulty. However, when it goes to the Senate, that will be another story. In the Senate, we know there will be 53 Democrats, 51 Democrats and 2 independents who caucus with the Democrats, and 47 Republicans. In order to pass a complete repeal of the Patient Protection Act, you would need 60 votes in the Senate because of the Senate filibuster rule. It takes 60 Senate votes to move to consideration of a vote on the floor of the Senate. So with the Republican minority only having 47 votes, they would have to pick up 13 votes in the Senate to close down a filibuster. The term of art is cloture. At that time, but at this point they're not going to be able to do it. It's very doubtful that they could convince 13 Democrats to come across the aisle. Regardless of that, the Senate Majority Leader Harry Reid from Nevada holds almost absolute control of what votes are considered on the Senate floor. That being the case, I don't see any scenario where Senator Reid would allow a vote to completely repeal health care reform to come to a vote on the Senate floor. We also know that President Obama is still in the White House, and if a complete repeal bill should pass the Congress, he in all likelihood would veto it. So what's that mean? Well, it means that we're going to see a lot of activity on health care reform next year, but I think it's going to be in the way of incremental repeal of certain provisions. We will also see an effort by the Republican majority in the House to deny funding for certain elements of the Patient Protection Act. There will be what are called oversight hearings. Certainly Secretary Sebelius, Secretary of Health and Human Services, will be called to the House, to the Congress repeatedly to justify implementation of the Health Reform Act. But we've already seen parts of the Act being implemented by Health and Human Services. So it's a long way of saying that although the elections will have an impact on health care reform and implementation of the legislation, to expect completely repeal in 2011, in my view, just won't happen. If the White House should turn to the Republicans in 2012, then we all could see an attempt in 2013 to completely repeal the Act. With that, Dana, if you could change a slide for me.
I have it on the overview of the PPACA.
Yes. This was signed into law on March 22nd, 2010. As you know, the House of Representatives passed their version of the bill in late 2009. The Senate passed its version of the legislation on Christmas Eve. The final version was signed into law by President Obama on March 22nd, 2010. As passed, the bill extends insurance coverage to about 32 million currently uninsured individuals. It provides subsidies for up to 400% of the federal poverty level, greatly expands Medicaid, includes an individual mandate starting in 2014, where there would be a penalty of $695 for an individual or $2,900 for a family for failing to have health care insurance. There's also an employer mandate that begins in 2014. There is what's called a free rider penalty if an employer with 50 or more employees does not provide affordable coverage beginning in 2014. Also in 2014, you would have the insurance exchanges. These will be state marketplaces where individuals and employers would be able to buy insurance if they chose. If you change the slide, Dana?
Go ahead.
Implementation of the Act, implementation will be a 10-year process. Immediate changes went into effect this year and will go into effect next year. There will be additional changes coming in online in 2012, 2013, with the most significant changes going into effect in 2014 and beyond. Those, again, being the individual mandate, the employer mandate, Medicaid expansion, the health insurance exchanges, etc. Dana, if you could change the slide for me. Let me just go through what's happened in 2010 with respect to insurance reforms first. HHS has created a national high-risk pool for individuals in high-risk categories who currently don't have insurance. Insurance companies are now required to provide coverage to allow adult children up to the age of 26 to remain on their parents' coverage. Prohibits the individual and group plans from placing lifetime limits on the dollar value of coverage, including a prohibition on denying children coverage based on pre-existing conditions. All new health plans will provide at a minimum coverage without any cost sharing for prevention services that are rated A or B by the U.S. Preventive Services Task Force. This year there's been created a temporary reinsurance program for employers providing health insurance coverage to retirees over the age of 55 but not yet eligible for Medicare. And also this year there's a requirement that health plans will have to report the proportion of premium dollars that are being spent on clinical services, quality, and other costs, and provide rebates to consumers if that share of the premium spent on clinical services and quality is less than 85% for plans in the large group market and 80% for plans in the individual and small group market. We will see the regulations on the medical cost ratios coming out of Health and Human Services next week. We expect that those regulations will put into the 85% category wellness and prevention activities, case management, and disease management. Continuing with the implementation in 2010, if you could change the slide for me, Dana. With respect to wellness and prevention, there's been created the National Prevention, Health Promotion, and Public Health Council. The council is charged with developing a national prevention strategy. That prevention strategy was released by the council in October for public comment. ACOEM is in the process of putting together its comments on the national strategy, with the final strategy due to be submitted to Congress in March of 2011. Also, this is the first year of what's known as the Public Health and Prevention Trust Fund, which appropriates $5 billion through 2014 and $2 billion for each subsequent fiscal year for prevention and public health programs. This is a trust fund, so technically it's not subject to the congressional appropriations process, although Congress has the authority to allocate how the monies are spent. They don't have the authority to deny an appropriation for the trust fund. Also this year there's been established a nonprofit patient-centered outcomes research institute to conduct research that compares the clinical effectiveness of various medical treatments, medical devices, etc. With respect to the workforce, there's been established this year a National Health Care Workforce Commission that will coordinate federal workforce activities and make recommendations on workforce goals for the health-related workforce. If you could change the slide for me, Dana. Next year, we're going to see, with respect to wellness and prevention, for Medicare-covered preventive services, there will be no cost sharing for a Medicare participant for any of the recommended A or B services by the U.S. Preventive Services Task Force. And it waives Medicare deductible for colorectal cancer screening tests and authorizes Medicare coverage for a personalized prevention plan, including a comprehensive risk assessment. Also next year will be the first year of what was expected to be a grant program, where grants would be provided to smaller employers that establish comprehensive wellness programs. At this point, no funding has been provided for that grant program for 2011, and I don't expect that we'll see money appropriated for it for next year. With respect to the medical home, next year we will see a new Medicaid state option to permit certain Medicaid enrollees to designate a provider as the health home, and provide states who take this option with 90% matching federal payments for 2 years for costs related to the medical home services. This, to a great extent, is a demonstration program or a pilot program looking at potential delivery benefits in a patient-centered medical home. Going forward, Dana, to the next slide. In 2012, providers will be eligible to organize as accountable care organizations, or ACOs, that voluntarily meet quality thresholds, and in turn they'll be able to share in the cost savings that they achieve for the Medicare program. For an ACO must have at a minimum 5,000 Medicare participants to qualify as an ACO. There have been some antitrust concerns voiced with the creation of accountable care organizations. The U.S. Department of Justice and the Federal Trade Commission are expected shortly to issue regulations that will provide substantial antitrust waivers for ACOs. The insurance industry has expressed concern with the fact that antitrust limitations are going to be waived for the ACOs. The insurance industry sees the ACOs as a potential major competitor moving forward, not only in Medicare, but if the ACO concept proves to work for Medicare participants, it's entirely likely that employers could start looking at ACOs for providing medical care to their employees. Also in 2012, the Centers for Disease Control is required to provide technical assistance and other resources to evaluate employer-based wellness programs. They will initiate a national worksite health policies and programs survey to assess employer-based health policies and programs, and to begin determining the return on investment that employers can have for investing in wellness and prevention programs. Next slide, please, Dana. In 2013, there will be a 1 percentage point increase in federal matching payments for preventive services in Medicaid for states that offer Medicaid coverage with no cost sharing for services that are rated A or B by the U.S. Preventive Services Task Force and for certain recommended immunizations. Next slide. This is where we get into the real meat of healthcare reform. The first thing will be the employer mandate. Employers with at least 50 full-time employees will face penalties if no coverage is offered to the employees, and full-time employees receive a tax credit to purchase health insurance through an exchange. The employer will be assessed a fee of $2,000 per full-time employee, excluding the first 30 employees. If coverage is offered, but it's not affordable, and at least one full-time employee receives a tax credit to purchase affordable health insurance on the exchange, then the employer will also face a fine, the lesser of $3,000 for each employee receiving a premium credit, or $2,000 for each full-time employee, excluding the first 30 employees. The formula here is a little difficult to follow. I appreciate that. In 2014, there will also then be the individual mandate. So require U.S. citizens and legal residents to have qualifying health coverage. There is a phased-in tax penalty for those who don't have coverage. This will all be accomplished through the Internal Revenue Service. When an individual files a tax return, they will have to report on their tax return whether or not they have health coverage. The penalties for not having health coverage would be assessed through the individual income tax. As you've probably heard and seen, it's estimated the IRS will have to hire an additional 16,000 agents to enforce both the employer mandate and individual mandate provisions. This will be one place that the Republican leadership in the Congress will focus on trying to deny funding. That is, to deny funding to the IRS to either enforce these provisions and a prohibition on hiring additional staff and personnel to enforce the various provisions. Next slide. Also in 2014, we'll see the health exchanges. Some states may well have their health exchanges up and running in advance of 2014. Under this provision, states will create these exchanges through which individuals and small businesses with up to 100 employees can purchase qualified coverage. This again is one of the controversial aspects of the healthcare reform legislation. This is one of the aspects of it that several states have taken the federal government to court on, and I'll address the litigation a bit at the end of this presentation, at the end of the slide set. Next slide, please. Also in 2014, with respect to wellness and prevention, there will be employers will be permitted to offer employees rewards of up to 30%, potentially increasing to 50% of the cost of insurance coverage for participating in a wellness program and meeting certain health-related standards. This is somewhat controversial. Some would call it very controversial. There's a fear from the patient advocacy community and the disability community that providing a reward or a discount of 30% against the cost of a premium will in effect result in an increase in premium costs for those who are unable or choose not to participate in a wellness program. Also in 2014, all new health plans in the individual and small group market and all qualified health plans that participate in the health exchanges will be required to cover preventive and wellness services as well as chronic disease management. With that, Dana, if you could change the slide for me. I'd like to spend the next few minutes going a little bit deeper into the Patient Protection Act, Patient Protection and Affordable Care Act. Next slide, Dana. First thing, what are the consequences for employers in all of this? And there's been a lot of speculation about that. We heard earlier this week the governor of Tennessee say that in the case of his state, it would be cheaper for the state to discontinue providing health coverage to the employees of the state and instead pay the penalty to the federal government for failing to provide coverage. So there's a lot of issues that employers are going to be looking at. When is a plan no longer grandfathered? So if a health care plan meets the grandfather test, which I'll go into in a second, there's certain aspects of health reform that the health plan does not have to meet for a couple of years. There are HHS waivers, what are called limited benefit plans. These are plans that are offered by certain employers to provide a limited health insurance to certain low-wage employees. Employers are going to have to look at medical loss ratios and premium rate reviews. This again is that 85-15% test, whether or not the policy that's provided by either the insurance plan or in the case of a self-insured employer, if their plan meets that test. And again, how will organizations with lower wage workforces and high health plan premiums respond to potential penalties for not providing affordable insurance to their low-wage employees? At what point will it make sense for the employer to drop coverage and pay the penalty to the federal government? Then the issue there is if the employer drops coverage, what needs to be done for to encourage the employer to keep making the investment in wellness and disease prevention and health promotion activities? Early anecdotal information we're seeing is that many large employers, although they're considering getting out of providing health insurance, will continue to invest in disease prevention and health promotion as critical parts of making sure that their workforce continues to be healthy and productive. The other challenge for employers will be the potential of having to face challenges in 50 different states and meeting a host of different reporting and administrative tasks to the extent that each state, through the health exchanges, implements their health exchange a little bit differently. Next slide, please, Dana. Some of the key employer provisions. You've got the new requirements that go into effect in 2011, and some of these have already gone into effect, to cover dependents up to age 26, no lifetime dollar limits on overall benefits, restrictions on annual dollar limits on overall benefits, and no pre-existing condition exclusions for children under 19. These are what employer-provided health insurance has to look at today. Next year, there'll be no use of FSAs, HSAs, or HRAs for over-the-counter medicines. It's unclear right now if there will have to be some kind of prescription document provided to support the need for an individual to purchase an OTC medicine. There'll be an increased penalty next year for the use of a health savings account for what HHS will determine to be non-medical expenses. And a major employer provision, again, will be when does the employer decide to relinquish grandfathered plan status? Many insurance plans and ERISA plans are looking at that right now. Next slide, please, Dana. Beginning with the 2012 tax year, and this is a change from the original law. The original law would have applied to the 2011 tax year. But beginning with the 2012 tax year, an employer will be required to report the value of health benefits on the W-2. You'll see in parentheses on the slide, January 2013. That reflects the date that the W-2s will be provided to the employees. So it's applicable for the 2012 tax year. Beginning in the 2012-2013 time frame, employers will be required to provide a summary of benefits and coverage, etc., to plan enrollees. Employers will be required to auto-enroll new hires in a health plan. There will be a limit on maximum FSA amounts to $2,500. An employer will be required to notify employees of the availability of and potential eligibility for participation in the health insurance exchanges, and also the ability to take advantage of tax credits for low-income individuals. Also in 2013, there will begin a Medicare surtax for certain high-income individuals. The Medicare surtax is one of the items being used to help pay for health care reform. Next slide, please, Dana. In 2014 and beyond for employers, of course, there will be the employer penalty for not offering coverage or for offering coverage that is not deemed comprehensive or affordable. Employer subsidy vouchers for certain employees whose coverage approaches unaffordability. There will be additional employer plan requirements in 2014. No annual or lifetime limits on essential benefits. Bans on waiting periods that are longer than 90 days. And ban pre-existing condition exclusion clauses for adults. In 2014, the wellness incentives under HIPAA will be increased from 30% of a premium cost up to as much as 50% of the premium cost. And again, there will be a 40% excise tax on higher cost plans. This is the infamous Cadillac plan, the tax on Cadillac plans. Next slide, Dana. I want to spend a little bit of time talking about grandfathered plans and what that means, because again, many Many plans, many ERISA plans are looking at this right now. Plans will lose their grandfather status if they choose to make significant changes that reduce benefits or increase costs to employees. This could include changing a carrier, going from one insurance carrier to another. You would lose your grandfather status. Any changes in coinsurance that increase employees' share of medical payments, going from an 80-20 split, for example, to a 70-30 split. Any increase in fixed payment amounts of more than medical inflation. Any increase in co-payments that exceed the greater of medical inflation. Or a decrease in employer contributions to premiums by more than 5% below the level that was in place on March 23, 2010. Or elimination of any benefit for diagnosis or treatment, or any part of a treatment for a particular condition since March 23rd. Those things, by doing that, a plan would lose its grandfather status. If you're deemed to be a non-grandfather's plan, then immediately you become I'm sorry, Dana, could you change this slide for me? If you lose your grandfather status or you decide you no longer need to be grandfathered, then you'll become subject to a host of requirements, and these requirements could go into effect as early as 2011. 100% coverage of preventive health services. This would be 100% coverage, no deductibles, no co-payments, etc. You become subject to an HHS approved internal appeals process and external review process. There'll be non-discrimination rules, elimination of prior authorization or higher out-of-network cost sharing for emergency, OBGYN, and pediatric services. Requirements to file financial reports with the Health and Human Services and/or state insurance departments. Beginning in 2012, file quality of care reports with Health and Human Services. Beginning in 2014, cover routine costs for people in clinical trials. And beginning in 2014, cost sharing limits not to exceed certain HSA maximums. Dana, could you change the slide for me? Talk a little bit about the medical loss ratio and premium rate reviews again. Again, HHS is expected to issue these final regulations as early as next week. These rules require health plans to report the proportion of premium dollars that are spent on clinical services, quality, and other costs. The plan will be required to provide a rebate or the amount of the premium premium spent on clinical services and quality that is less than 85% for plans in the large group market, 80% for plans in the individual and small group markets. These rebates are effective January 1, 2011. So for a plan that reports that their medical loss ratio for 2010 falls below that 85% or 80% threshold, they'll have to begin making rebates to their participants beginning next year. Again, from ACOEM's perspective, there has been some concern that insurance companies will assume a greater responsibility for certain wellness, disease prevention, and disease management programs, and to assign those numbers, the value of those programs, those costs, to their 85% test. And the concern there being that insurance plans may do that without the involvement of corporate medicine. And so this is an area, if your employer sees a need to do that or is asked to do that by the insurance plan, you need to ensure that corporate medicine still has a role in providing those services to the employees. Next slide, please, Dana. These are the mini-meds. These are annual limits on the dollar value of essential health benefits. Under the original Act, the annual dollar value limits cannot be lower than, and you see the values on the slide here. For 2011, there cannot be an annual value limit of lesser less than $750,000. This was very controversial. A number of employers, I think you probably read about McDonald's being one of them, were concerned that because of these limitations, they would not be able to meet them. They were providing essentially a low-cost health insurance coverage to low-wage workers, and there was concern that they no longer be able to provide that coverage. Next slide, please, Dana. These were known as limited benefit plans or mini-med plans. They had annual limits that were well below the annual limits in the legislation. HHS has granted waivers to a number of companies, number of employers, to allow these mini-med plans to continue. As of the last time I looked, there were 60 to 70 of these waivers issued, everywhere from large multinational corporations down to local small businesses. Next slide, please. For employers, again, there's the issue of the free rider mandate. And this is the issue of whether or not, come 2014, it's going to be worthwhile for an employer to continue providing health insurance coverage to its employees, or will it be cheaper to instead pay the penalty, pay the free rider penalty, and discontinue providing health insurance coverage to employees. We don't know how this is going to shake out. We do know that there are employers looking at doing this, looking at discontinuing their health insurance coverage come 2014 and paying the penalty. We know that there are employers that are looking at doing this but continuing to invest in wellness and prevention programs. Again, I think the challenge for occupational medicine and corporate medicine is to make the case to employers that if they're no longer going to provide health insurance coverage, that there's still a direct value, a return on investment, to continue to invest in things like wellness, prevention, disease management, etc. But this is probably one of the, if not the most significant issue for employers to look at in the years to come, and for corporate medicine to look at in the years to come. What happens if the employer no longer provides health insurance? What's needed to be done to ensure a continued healthy and productive workforce? Next slide, please, Dana. These are the Cadillac plans. Employers are going to have to start keeping an eye on the Cadillac plans. This goes into effect in 2018. Imposes an excise tax on insurers of employer-sponsored health plans that have aggregate values that exceed $10,200 for individual coverage and $27,500 for family coverage. One of the issues here that's been raised with me by at least one corporate medical director is whether or not, and we're a long ways away from HHS writing the rules to implement this, the issue that's been raised, would the value of corporate worksite-based medical clinics have to be factored into this overall threshold value? Are we looking just at the value of the premium provided to the employee, or will the employer have to factor in other expenses that are related to health and wellness? It was raised to me again by a major corporate medical director for a major corporation. It's something that people are starting to wonder about, but again, we are a long ways from seeing any regulations on the Cadillac plans. Next slide, please, Dana. The threshold amounts will be increased for any company that can show it has higher health care costs because of the age or gender of their workers. And this tax is imposed on the issuer of the health insurance policy, or in the case of a self-insured plan, the employer. Next slide, please. One of the key parts of the Patient Protection and Affordable Care Act was health performance and the role of wellness and prevention programs. President Obama spoke often about prevention being an underpinning. of health reform. At this point, there is a lot in the Patient Protection and Affordable Care Act that could produce rewards, benefits for wellness and prevention. As I mentioned, there's been created a National Prevention and Health Promotion and Public Health Council. This council is developing a national prevention strategy. I was at a meeting yesterday of the Institute of Medicine, and they were talking about Healthy People 2020 and the goals and objectives that will be laid out in Healthy People 2020, which is due to be released on December 2nd. The question that they were looking at is what is going to be the interaction and linkage between the National Prevention Strategy and Healthy People 2020. A key aspect, again, of health reform has been the coverage of preventive services. Health plans will have to begin providing first dollar coverage for preventive services. There is a small business grant program that I mentioned earlier for comprehensive workplace wellness programs. Unfortunately, the first year of that program, 2011, there has been no money authorized to be spent for it. We also don't know what it's going to mean to be a comprehensive workplace wellness program. We met yesterday with some folks here in Washington, D.C. to begin sketching out what should be meant when the federal government talks about a comprehensive wellness program. CDC has been given the authority to conduct research and provide technical assistance related to employer-based wellness programs. And again, a key aspect for prevention are the employee incentives that can be offered beginning in 2014 for participation in wellness programs. Currently, under HIPAA, you can provide an employee with a 20% incentive against the premium cost. Under Patient Protection and Affordable Care Act, that incentive can go up to 30% and as high as 50%. Next slide, Dana. As I mentioned earlier, under prevention, we do create a national prevention strategy. As part of that, there will be an advisory committee appointed that will include individuals with expertise specifically in preventive medicine and workplace health promotion. ACOEM has nominated 2 individuals to serve on that advisory committee. As of yesterday, that advisory committee had not yet been appointed. Next slide, Dana. As I mentioned, one of the requirements is to create a national prevention strategy. That strategy is due to be provided to Congress on March 23rd of 2011. It also created a Prevention and Public Health Trust Fund that is to be used to expand and sustain funding for prevention and public health programs. There was an initial $500 million allocated for 2010. There will be $750 million for 2011. This trust fund is, as I mentioned earlier, is not subject to the congressional appropriations process. However, it has already been the target of at least one legislative attempt to transfer funds from the trust fund to other purposes. I would expect that in 2011 we will see a number of efforts to take monies from the trust fund to pay for other activities that are unrelated to prevention and public health. Also, as part of the National Prevention Strategy, there will be task forces created on preventive services and community preventive services to develop, update, disseminate evidence-based recommendations on the use of clinical and community-based prevention services. You can skip the next slide, Dana. And the next one, too, if you don't mind.
Okay, are we at workplace wellness, small business?
Okay, here we go. We're good. Wanted to dig a little deeper into the Small Business Grant Program, and although it doesn't look like this grant program is going to be funded at least in the near future, I thought if you'd like to see what the required components are, of that grant program. And this goes again to what would be meant by the term comprehensive wellness program. The required components would be a health awareness initiative, efforts to maximize employee engagement, initiatives to change unhealthy behaviors and lifestyle choices, including counseling, seminars, etc., and supportive environment efforts, including workplace policies that encourage healthy lifestyles, healthy eating, increased physical activity, etc. Again, although there's not funding for these small business grant programs, there is interest among some groups, including ACOEM, in beginning to work with the Health and Human Services to begin better defining what's meant by a comprehensive wellness program. The term comprehensive wellness program sometimes is used pretty loosely, and it would be good to better define what's meant by that. Next slide, Dana. Want to just talk a little bit more about the workplace wellness and what CDC will be doing. The Act specifically directs the CDC to, one, provide employers with technical assistance, which could include consultation, tools, and other resources to evaluate employer-based wellness programs. Build evaluation capacity among workplace staff by training employers on how to evaluate employer-based wellness programs. Both of these bullet points are very important because, again, there's been a lot of talk, a lot of interest in wellness, but there's not been much put together to evaluate and document the return on investment for these programs. And the last point there would be conduct a national worksite health policies and program survey to assess employer-based health policies. I will say at this point that if CDC takes this authority and runs with it, there could be a great benefit. But ACOEM and others are going to have to interact very closely with CDC to make sure that CDC uses this authority and in the end provides a benefit, the anticipated benefit. And again, I think this is an area where corporate medicine can be very helpful in helping develop the role that CDC should play in exercising this authority. Next slide. Again, this is the incentives for employees to participate in wellness programs. One of the key points is the second bullet there. Employers must offer an alternative standard to individuals for whom it's difficult or inadvisable to meet the standard. This would include a person with a heart problem, for example, who would not be able to, say, participate in a exercise program. Next slide, Dan. There's been a lot of talk and a lot of interest in the whole concept of the patient-centered medical home. The patient-centered medical home and the use of that concept to deliver affordable health care is an important part of the Health Reform Act. There's a state option to provide health homes for chronic conditions. This, again, is viewed by many as a demonstration project as a first step to demonstrate the value of the patient-centered medical home. There's created a pediatric accountable care organization, again as a demonstration project. There's established within the Center for Medicare and Medicaid a Center for Innovation. There's also an advanced primary care demonstration project. Patient-centered medical home is an important issue for occupational medicine and for corporate medicine. It is still unclear to me and others how occupational medicine and corporate medicine will work within the patient-centered medical home. As you well know, the patient-centered medical home is a concept that was developed by other medical specialties. And so ACOEM is looking at how best to interact with the patient-centered medical home. And as these demonstration projects go forward in the next few years, how occupational and corporate medicine can participate. I think, again, this is an important role for corporate medicine. not only do we have to articulate that we want to be part of patient-centered medical home, but we also have to articulate why it's important that the work site be included. Next slide, Dana. In my opinion, there's a nexus between the patient-centered medical home and the accountable care organizations. The ACOs are organizations of healthcare providers that would agree to be accountable for the quality, cost, and overall care of Medicare beneficiaries. Under the Act, an accountable care organization would have to have a minimum of 5,000 Medicare participants. But as I mentioned earlier, there's already employer interest in looking at the ACO concept and possibly moving from an employer-provided health insurance program to an employer-provided access to an ACO. This is of some concern, increasing concern, to the health plans who see ACOs as being a potential competitor, a potentially significant competitor. Again, for ACOEM, for occupational medicine and corporate medicine, the question will be how the workplace factors into an accountable care organization, how the delivery of occupational medicine services factors into an ACO. And this is one where we're going to have to articulate the reasons why there's a role for the workplace in occupational medicine in the ACO model. And we can't wait until the ACO model demonstrates proof of concept. We're going to have to be at an earlier point in there. Next slide. Next slide, Dana.
On comparative effectiveness research?
Yes. Yep. Okay. There's created a nonprofit patient-centered outcomes research institute that will take on the role of supporting comparative effectiveness research at the federal government level. It is overseen by an appointed multi-stakeholder board of governors and will be assisted by a series of expert advisory panels. There's been some misunderstanding for quite a while as to what comparative effectiveness research will do and not do. There are some who assert that the comparative effectiveness research will be the first step towards rationing of health care. There's a specific provision in the law that says that findings from comparative effectiveness research may not be construed as mandates, guidelines, or recommendations for payment, coverage, or treatment, or used to deny coverage. Comparative effectiveness research, treatment guidelines, etc., is one of the ways going forward that the federal government will be looking at trying to improve the quality and reduce the cost of health care. Next slide, Dana. Issues to consider for corporate medicine and opportunities for OEM physician involvement going forward. I've touched on several of these during the last hour. You know, what is the role of corporate medicine in the patient-centered medical home and the accountable care organization? Again, we do not want to wait until these delivery models are fully developed. We need to be involved at an early stage, as possible. Another issue is worksite-based wellness and disease prevention programs. There's a lot of interest from the employer community in these programs. To a great extent, corporate medicine will be the front line of articulating the value of these programs to employers and demonstrating the return on investment that an employer can see from these programs. The medical loss ratios in the worksite, again, as the insurance plans, including the self-insured plans, scramble to make sure that 85% of the premium goes to clinical services in healthcare, including things like wellness and disease prevention. Corporate medicine will need to really supervise how that's being done by the health plan and assert the role of corporate medicine in wellness and prevention and not allow the insurance plan to solely take that over. For corporate medicine also, there's just the future of employer-provided health care. Your employers are going to be looking at that, at least some of your employers are. And you'll have the opportunity to be part of the team within the employer that makes the decisions on how best to move forward. And the last point is integration of health with workplace safety and health. One of the things where ACOEM's been involved in the last several months is trying to make the case that a healthy workforce is also a safe workforce. ACOEM is in the process of putting together a white paper on the value of integrating wellness with safety and health. And I think that can be an important argument moving forward as healthcare reform is implemented. That not only are we talking about the health of individuals, but we're also talking about workplace health and safety. Next slide, Dana. The road ahead, I've spoken a bit at the beginning about legislation, what Congress might do next year and the year after. There's also litigation. There are suits filed in Michigan. There's a suit filed by the Attorney General of the Commonwealth of Virginia. And there's a suit filed by a number of states led by the state of Florida, challenging portions of health care reform, primarily challenging the provisions that primarily challenging the individual mandate and the requirement that states take on a larger share of Medicaid. Some of the arguments have been scheduled for later this year in the courts. I think it's safe to say, with the way our judicial system moves at a snail's pace, regardless of what the initial court decisions are, whether they support the plaintiffs or not, it will be many years before these cases finally reach the Supreme Court for a final decision. On the regulatory side, there's expected to at least be 40,000 pages of regulations written by HHS, the Department of Labor, and the Internal Revenue Service. As those regulations are being written, ACOEM and corporate medicine, we need to make sure that we're participating in that rulemaking process. With that, Dana, if you'll turn to the last slide, I'll be glad to answer questions.
Great, thank you, Pat. I'm going to, at this time, stop the recording, and then I'll momentarily open up all phone lines for the question and answer session.